My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. Welcome to the National COVID-19 Clinical Rounds for Emergency Department, Patient Care and Clinical Operations. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 ED challenges and successes in patient care and clinical operations. If I'm a physician or nurse preparing my emergency department to care for an avalanche of COVID-19 patients, the clinicians I want to learn from are those who have prepared the most and have the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have already collaborated. This is not intended to be redundant or replace any organization's initiatives. I've seen the websites of many organizations who have really helped their members and constituents plan and respond to COVID-19, and they're wonderful. This is intended to be a sharing of clinical experience, not recommendations or guidance. I appreciate the National Emerging Special Pathogen Training and Education Center, NETEC, and the regional treatment centers for their support for these rounds, and to the American College of Emergency Physicians, who has been especially helpful in developing these emergency department focused rounds. Thanks to Project ECHO, Dr. Bruce Strumminger and his team for the peer-to-peer learning platform we're using for these rounds. I'd also want to acknowledge, there's a lot of glue and connectivity that has to happen to do any kind of response, anything like this, a national emergency. And a nonprofit corporation a nonprofit organization was very helpful in making the dots be connected for this. At 2 p.m. Eastern Time today, April 2nd, CDC will be having a clinical outreach and communication activity call on clinical management of critically ill adult patients with coronavirus disease. I would encourage you to participate in that. Like the ECHO clinical rounds that we are now doing right now, the CDC COCA calls are also recorded so you can listen in at a later time. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. The COCA calls are also important resources. In terms of upcoming ECHO clinical rounds, all are noon Eastern Time. The critical care round Tuesdays, part 3, the third in the series, will be Tuesday, April 7th. We'll be getting up an update on what's changed in the past 2 weeks from our first critical care round speakers from Emory and the University of Minnesota. For the emergency department rounds, today is the first one. We'll plan on doing these on Thursday noon. We also have plans to do clinical rounds on both EMS and alternate care sites. They're still in the planning stages. For the 2 ECHO clinical rounds we've had, which have been focused on critical care, we've had participants from all states and many countries, predominantly physicians, nurses, and EMS clinicians. Notably, many non-intensivists have participated in the 2 critical care rounds. We have an interest with these rounds in making them as interactive as possible by engaging expert discussants and crowdsource polling. We've picked out major themes from the many questions, hundreds of questions we've received, and hope to cover some of those. For those on the Hollywood Square tiles, please raise your hand to ask questions or respond to a question. This is a little bit like merging clinical rounds, ground rounds, and webinars to a virtual peer-to-peer learning environment. It's a little bit clunky as we get used to it, but I think it's already served an important, valuable resource. We also have a polling function in the chat room to crowdsource experience, and we'll get to that slide in the coming minutes. So with that, I'll turn it over to Dr. Bruce Strumminger, who's our clinical lead from Project ECHO. Thank you.
Great, thank you, Rick, and welcome everyone. I'm just gonna quickly go through a few housekeeping items. Hopefully you can see my slides. Great. So the first is Please reserve the Q&A function on Zoom for questions and comments regarding the presentations, and use the chat function for questions regarding technical or logistical issues. So we'll try and keep the more emergency medicine related questions in the Q&A function. The slides and a link to the video recording will be shared after the session via email with everyone who registered. Presentations will be linked to the most recent reminder as well. This session is being recorded and your attendance is consent to be recorded. Thank you for joining us. And there will be CME and continuing professional development credits available through the University of New Mexico, and we'll be sharing a link in the chat at the end of the session, and you'll have up to 48 hours to do that. That includes a survey for feedback to help us improve this program and this educational initiative. So we please encourage you to take advantage of that and give us the feedback. So this is the question. I'll hand it back to Rick to go over this crowdsourcing feedback we're hoping to get live during this session. Go ahead, Rick. Rick, you're muted right now.
Yeah, Bruce, I'm not good at the mute unmute piece after all this time. Okay, so we really believe these are important questions that we really need answers to. When I say answers to, as the nation is responding to this, things are moving really, really quickly, and knowing contemporaneously exactly what's going on is really helpful. And I share this with the FEMA Healthcare Resilience Task Force that then gets forwarded on up through various channels to leadership. So the questions, your ED volume in the past 72 hours, increased, decreased, or the same? Just that simple question. We've actually learned some emergency departments have had significant decreases in volume, which is surprising and maybe not surprising. What is your #1 clinical pearl, the clinical care of patients for COVID-19's patients in the ED? What is the single best clinical operations change you have made in response to COVID-19? And then what is the single biggest clinical operations challenge you've had in the past 72 hours? Answering those questions will get us all a little bit of a handle in real time across the nation, and actually from other countries that have joined in a way that is otherwise difficult to acquire. All right, so at this juncture, Bruce, any other housekeeping pieces before I then turn it over to our first speaker?
No, please go ahead.
Thank you. It's my pleasure to introduce Dr. Susan Stern. Dr. Susan Stern is the professor and founding chair of the Department of Emergency Medicine at the University of Washington in Seattle, Washington. She completed an emergency medicine residency in 1987 and a research fellowship focused in resuscitation science in 1991, both at the University of Cincinnati. She's a past member of the board of directors of the Society for Academic Emergency Medicine and is president-elect of the Washington State chapter of ACEP. Thank you, Dr. Stern, for joining us.
Can I share my screen now?
Yes, please do.
Okay. All right, is that working? Not good at this. So
no, we're all working through this together. It's working great.
Okay, so well, good morning, everybody. It's morning for me on the Pacific coast here. Good afternoon to you guys. I want to again thank you, Rick. As you said, I'm currently the chair of the Department of Emergency Medicine. It's an honor for us to be able to share our experiences here in Seattle. I suspect our experiences here are probably not going to be as dramatic and as extensive as the next speaker, Dr. McGreevy. But I will share what I've learned, and I'm happy to answer any questions. Let me see if I can get this to change. My slide changer. So I'm sorry, I'm your first glitch. My slide changer is not.
So Susan, just go ahead and hover over your presentation, click on it, and hopefully that'll move it forward.
Oh, there we go. Okay. So not the usual. Okay. So my objective for these slides, and I'll get through them very quickly because I think the most valuable part of this will be a rich discussion and question and answer, but certainly we want to provide some insight and tools to assist readying hospitals and emergency departments to respond effectively to the COVID-19 pandemic, sharing our clinical and operational experiences and observations. And at the end of this presentation, there's 2 links to some resources and clinical tools that are open to everybody. One is our website that includes a repository of different protocols that we've developed, as well as the UW Medicine website for that. So let me just move on from there. So as I said, our department is responsible for about 3 emergency departments within the city of Seattle. One of those is Harborview Medical Center Emergency Department, which is a high volume, it's a county hospital. It's level 1 trauma and burn center for 4 states, fondly known as the WWAMI region, which is Washington, Alaska, Montana, and Idaho. It's a comprehensive stroke center and a general referral center for really critical care in the Pacific Northwest. We also are responsible for staffing and operationalizing the University of Washington Medical Center Montlake Campus Emergency Department, which is very much a tertiary, much more quaternary care center. Typical cancer care, transplant, cardiac disease, high-risk OB, and neonatal ICU. And then on the other end of the spectrum, we also have a community hospital that we staff, which has a significant elderly population. So these hospitals are very, very different, yet we need to get them all ready somehow for this pandemic. And while they're different, they serve different patient populations, their volumes are different, and geographically, their structure is different. But what I found in working, and again, I have a great team of people, 3 wonderful medical directors and associate medical directors. What we have found is that the principles are the same, and that's what I'm going to share with you today. So here's a little bit about the Seattle story. The first case of COVID-19 or SARS-CoV-2 diagnosed in the United States was actually diagnosed on January 20th, 2020 in Snohomish County, Washington. And I'm going to hover, hopefully you guys can see, Snohomish County is right here in Western Washington. Seattle is in King County right here. Those are the 2 most populous counties in the state. And that first patient was actually, he had recently traveled to Wuhan, China. He did recover and did okay, was hospitalized, but did recover. About a month later, and this really set things off here, both all of the efforts and raised everybody's suspicion and angst and awareness. A resident was diagnosed, a resident of a long-term care facility on the east side of Seattle was diagnosed with coronavirus. Shortly after that, there was an epidemiologic investigation. Really what happened was there were several residents of that long-term care facility that went on to get sick. That long-term care facility was in a close proximity to a community hospital on the east side of Seattle and King County. And because it was so close, they sent all of their patients to that one facility, and that facility became quickly overwhelmed, or at least very, very crowded. And as you'll see as I go through these slides, that ultimately led into a much more regional response, and again, raised the awareness of everybody in this, certainly in King County and Snohomish County and in the state. The epidemiologic investigation of that long-term care facility, it found 129 cases were associated with, positive cases were associated with that facility, 81 residents, 34 staff, and about 14 visitors. There were 23 deaths. As of March 18th, there have been a total of 167 confirmed cases affecting 101 of those residents in that facility, 50 of their healthcare personnel, and 16 visitors. As of March 18th also, and unfortunately, the Department of Health in King County was able to observe that there were 30 long-term care facilities, so 29 additional facilities with at least 1 confirmed case of COVID-19 identified within King County. So setting off a lot of alarms, and that really set off the big picture. So where are we now today in Seattle? We're not where New York is, thank goodness. But I stand in solidarity with my colleague in New York and everybody around the country and around the world who's suffering this and working through this. Right now, as of like 11 o'clock last night, you can see on this is the King County website. It's updated every day. There have been 5,984 confirmed cases, most of which you can see are in Snohomish and King County, where they started. There were 247 deaths, which is 4.1%. We have been able to do 74,798 tests, and our positive rate is about 8%. Interesting, what we've been finding is that at least in this community, the positivity rate in the general public is higher than the positivity rate thus far in those healthcare workers that have been tested, which is a good thing. Not that we want it to be positive in the public, but it indicates that so far our healthcare team may be protected and that actions to protect them are working. Next slide just shows the exponential increase over these past couple of weeks in the confirmed cases, and basically it's really the cumulative caseload. So it's not really an exponential curve, but it shows how it's rising. With social distancing, our hope is that we're going to be able to flatten out our curve, and the Institute for Healthcare Metrics and Evaluation, which is part of the University of Washington and has received significant funding from the Melinda and Bill Gates Foundation, they have shown their projections have shown that there has been some flattening of the curve, and we're hoping that those are real. There's limitations and wide variations, wide 95% confidence intervals for that. So that's sort of some of the background. And so now I'd like to just talk a little bit about our response. And I'd like to start by sort of comparing our response, or the response of for this COVID pandemic response, to what we're all much more used to. We're unfortunately used to hearing about big MCIs, whether it's shootings or large plane crashes or car accidents, et cetera. We've drilled for those. We know how to do those, but they're very different. A typical response, there's all hands on deck very quickly. It's short-lived, hours to days. There's immediate, really high intensity, rapid, and then following that, there's a rapid de-escalation and recovery. And we regularly drill for that. We're prepared for that. And I would describe it as a sprint. It's a hard sprint, but it's a sprint. But if you compare the response to how we need to respond to this COVID pandemic, it's very different. And I think it's more challenging for a number of ways. The University of Washington stood up its response almost a month ago. When they heard about the failing long-term care facility, and the Department of Health and Human Services came to the aid of them, we stood up our incident command then, and we've been running full speed for 4 weeks, and we haven't even hit our surge. So this is a prolonged response. It's going to last weeks, but if not, more likely months. And we have to be prepared for that. We have to pace ourselves. We have to get a large team. We have to relieve each other. The initial intensity of such a response is really focused on planning and organizing. And it's every day from 6:30 in the morning till about 10 at night. You're in meetings, and then you come out of those meetings and you have tasks, and it's all across the institution. It's really important that you engage the entire institution, and that your incident command at your hospital level is bringing everybody on board, from the CEOs and nursing leadership and physician leadership, infection control, the ICU, the emergency department, supply chain, materials management, space planning, finance, media, you name it, they have to be on board. It's later in the response where the emphasis is on clinical care. The patients will come, and you know the advantage of a response like this is you have time to run up and really prepare. And so we're sort of at the end, leading towards the end of that run up. That run up is coming, and we're finalizing protocols and putting things into place and continuing to drill. We haven't drilled for a pandemic. The closest thing to this was H1N1, and we hadn't drilled for that, and then Ebola after that, but that was very different. That's a limited response. It's an intense response, but it's really about putting up walls and identifying space for a few very intense patients. So this is a marathon. There's much greater risk of fatigue and burnout. And then the other thing that I would say that I'm guessing Dr. McGreevy is seeing is that there's a real risk to the health of the providers on the front line. And so I think those are some key differences and things that we need to keep in mind when you're planning, and some really important lessons learned to take care of our patients. You need to take care of your teams. So what's the anatomy of the response? Well, I alluded to that, and I'd like to talk about these sort of 7 things on this slide, or 6 things on this slide. First of all, you need to set up an effective incident command structure. For us, we're a healthcare system with 4 hospitals, although I'm only responsible for 3 of the emergency departments. And we started with our incident command of the entire healthcare system, and then each hospital under has its own incident command and reporting up. It seems like a bureaucratic mess at first, but it really comes together with very clear a clear chain of command, and in all of those areas that I previously mentioned. Communication, operations and preparing the environment, clinical protocols, team preparation, partnerships and collaborations are key, and that's both internal and external. This is not an emergency department response, and this is not a hospital response. If we're going to be successful as a state, as a county, or even as a nation, it needs to be a regional collaboration because our resources are going to be very stretched. And so I'll talk briefly about all of these things. So communication. Set up a communication system really early. It may seem silly, but you cannot over communicate. We were in a much different place a month ago, and the angst of our faculty was not quite there, but it is high now, and I'm guessing even in places that haven't started to see this in their state, in their county, that the angst of the faculty and the nursing staff and everyone who works there is probably pretty high, because now they're watching what's happening in New York. And so you cannot over communicate. It's reassuring, and transparency along the ways is really important. So some things you can do: we send out near daily email updates. Sometimes they're more comprehensive than others. I have started bi-weekly Zoom meetings, and more so as we ramp up to surge. We have a repository of protocols and communications, which is open to the public. And again, I have the links at the end of this. I encourage faculty to go to those protocols and communications. We keep everything in one place so that there's only one source of truth. And UW-Medicine does the same, and all of our protocols go up on the UW-Medicine repository. I would say the other thing is that as we have moved, our experience is that as we have moved through this process, protocols have changed, and they've changed sometimes within, because our situation has changed. We learn more about the virus and transmission every day. The situation changes because it's less prevalent, and then it becomes more prevalent in the community. You may have increasing positivity rates. You may find that you're burning through PPE. And so there are many, many different reasons that you need to change protocols sometimes. It is the most rapid process improvement that I've ever experienced or been through. And what that can do, if you're not careful and you don't communicate the why, and you're not transparent, and you're not on top of it with communication, it can create more angst in your healthcare workers, and they can lose confidence. So again, I cannot state how important communication is early in the game, and make sure there's a clear chain of command. Operations and preparing the environment. I'm guessing Dr. McGreevy probably has even more to say about this than I do. A couple things. So the first thing is I would say the second thing on the slide is the first thing, and that is you want to figure out a way to decant the ED of patients who do not need to be there. You're going to need the space for surge, and you want to spread your healthcare workers out as much as possible, even if you're not in surge. You want to give them the social distancing that other people get by not going to work and staying home every day. That's almost impossible in a crowded ED, but even if you're not in surge, keeping those patients who don't need to be there out is better. It's better for the patients, and it's better for the healthcare. So as you'll see in the next couple of slides, we've set up a tent. We just opened it we've set up tents at each of our facilities, and they're opening at various paces this week and next. So we are screening patients at the tent, and if you don't need to be in the emergency department, you're either treated in the tent, or you may be directed to a non-respiratory type urgent care setting. Make sure, in order to do that, one way is make sure that your hospital is behind it, the media of your hospital is behind that, and really and the Department of Health sends out messaging to educate the public regarding the appropriate use of the emergency departments and testing. And this is not different than what they do for the flu. You've taken care of that. You want to start considering whether you want to cohort your COVID-19 or suspected COVID-19 patients in hot and cold zones. That creates, I think that creates a safer environment for both the patients and the healthcare workers. If you're focused on those patients and you're really in your PPE nearly the entire time, you're not donning and doffing as much, and it also saves PPE. So I would highly recommend cohorting, and you may have to be creative by doing that. We have an old, relatively old emergency department at one of our facilities, and that's the county hospital. We don't have doors. So we've had to develop a hot zone, and I'll show you some pictures where we've been very creative in trying to put up barriers and in order to accommodate that. Tents and screening we talked about, identifying alternative urgent care settings near the emergency department for patients with minor non-respiratory complaints. And then the other thing is consider how you could use telehealth within your emergency department. You can use telehealth simply with phones. You can purchase iPads and put them in the room. And this reduces your healthcare worker contact. Your social workers don't have to go in the room. You can even take a history from outside the room, you and the resident together. The nurses can go in at one time and then check in on the patient through Zoom or chat and other ways. And this also saves, so it not only reduces healthcare worker contact, but it saves PPE. And you can also use it to monitor sicker patients if you put it on wheels. And so I'd highly recommend trying that. This just shows one of our protocols. It shows who to test. And I'm going to get to that. And sorry, I actually want to go to this one. This is our tent. You can see here, this was the guts of our tent. Here it's almost up and running, and here it is up and running, and right outside the emergency department. We just move patients through there as quickly as we can. And this is how it's set up. We have, these are all chairs, the X's. And it's still cold here in Seattle, so we start the heater running at 5 o'clock in the morning, and by the time it's opened, it's about warm, but that's what it takes. We have a computer, a phone charger. We actually have an X-ray right outside, portable X-ray right outside the tent, with some lead glass that we use to shoot chest X-rays. We do very minimal testing in the tent. We swab for COVID and do chest X-ray, and that's pretty much it. And it's considered a warm zone, so we use droplet and contact precaution while we're in the tent. Here's where I say be creative and think outside the box. The only way that we could actually set up our cohort, our patients, again, we have open bays. So we sat down together, we sat down on the whiteboard and really mapped it out and said, how can we do this? And we had to be creative because we had to identify a cold zone for Pyxis. We had to identify a way to get storage, the supply team in there and not walk through the hot zone, and keep the dirty utility room where it was and the clean equipment where it was. So this just shows it's a cartoon drawing, but we sat down and this is what we planned. We used the whiteboard and just really sketched everything out. Again, here you can see some of the barriers that we've had to put up to really make a protected space for people to work. So that's what you're seeing here, because these are otherwise you're constantly with open rooms and we don't have negative pressure in that area. This is the same thing. And then here, this is how we reuse our masks. Again, it's low technology, but it works. The other thing I would say is develop clinical protocols and do that as quickly as you can. My slide's a little bit out of order. I apologize for that, but an example is your testing protocol. You want to use, we are fortunate here, University of Washington was the first institution in the country to stand up testing on site. And so we were one of the first states to really get aggressive with testing. We can now test, I think our capacity is about 3,000 tests per day or close to it, or it will be that. Initially, it took 48 hours to get a test back. We are now getting them anywhere from 7 to 12 hours back, and they're developing a rapid test that you can get back in a couple hours, even 45 minutes if you time it right. But generally, it's a couple hours. So if you have limited, ideally, we'd be able to test everybody, because that's going to teach us about the epidemiology of the disease. We all know there's some asymptomatic spread, and we really want to get a visibility into how the disease is spreading. But the reality is, unfortunately, is we don't have the adequate testing. And if you are not fortunate to have as much testing as you need, and we still have to limit some of it here as well, because we are testing for the region as well, not just for our own population, then you need to prioritize your high-risk population and strategize your testing to preserve limited resources. So if you have patients in beds that are going to be able to go back to the SNF, you want to get those patients tested and see if they're negative and get them back. If you have a homeless population like Seattle, you're going to want to be able to test those patients as they come into the emergency department. And so we can talk a little bit about that if anybody has questions. Think about developing risk assessment algorithms to guide admission versus discharge and acute care versus ICU. We are just about finalizing a protocol for that. Again, that data is changing every single day. But consider that, because your beds are going to become a very, very precious resource, as Dr. McGreevy, I'm sure, knows. Intubation and resuscitation, I'm going to just gloss over very quickly for us. I think for everybody, but in particular for us at the county hospital, we thought about that a lot. We are now doing our major resuscitations for these patients in a room that's very different than we normally do it, because we take them into one of our few closed doors, negative pressure rooms, because intubation is considered an aerosol generating procedure. And so we have a few very limited negative pressure isolation rooms, and they're smaller than our normal resuscitation bays. So we have developed a protocol for that. We have an intubation kit, a bag. We have a checklist for that. And we've drilled for that. We've drilled with the nurses in simulation, et cetera, because you're doing this in a new room. You're doing it with PAPR, and some people have never even worn a PAPR. Things to think about is you want to avoid non-invasive positive pressure ventilation and high flow nasal cannula, because those are aerosolizing generating procedures. You want to avoid nebulized breathing treatments for the same reason, and use MDIs for your asthmatics. Consider early intubation, because you don't have NIPPV, and because once the patient is intubated, there's certainly less risk to the healthcare worker. Again, we've developed intubation kits, and we've developed resuscitation kits with vasopressors as well, and all the equipment we use. We try to bring as few pieces of equipment into the room. We don't bring a cart into the room like we normally would, because then you got to clean the cart. It's completely then has to be decontaminated. We favor the use of video laryngoscopy now for these patients over direct laryngoscopy. I don't know that there's definitive data on that, but theoretically you are less close to the patient, and so it allows you a little bit more distance. We use viral filters right at the end of the endotracheal tube. And then again, we have a repository of protocols and communications, and we built other protocols. But we have drilled for this, and I think it's really important. And you're, again, welcome to go to our website and see some of our protocols. Other thing I would say early on is partner with palliative care. We are not in a surge space right now. We're running up to surge space. We are not in crisis standards of care at the University of Washington, thank goodness, right now. But we have already, a couple weeks ago, already involved palliative care. In fact, they come down and round in our emergency department daily to check in, to get to know us, know our processes, know our patients. We meet with them regularly. They've educated our clinicians, and we continue to educate, develop talking points so that you can have those, your clinicians on the front line can start to have those conversations in a more comfortable way with family, matching goals of care with likely morbidity and mortality. Finally, really think about developing a process for implementation of your crisis standards of care. And that should be a regional response, not just an institutional response. You absolutely need an institutional team to do that, but it should be a regional team. And in fact, what you don't want to do, it should be such a regional response. You should not in your region have one hospital having to go on crisis standards of care when another hospital in the region has plenty of resources. So again, we have formed institutional and healthcare system triage teams, and they have, each team consists of 1 to 2 critical care and EM faculty, 1 senior nurse, and 1 clinical ethicist. These teams ensure a transparent, equitable, and consistent approach to the allocation of scarce resources. It takes that burden off the clinician. When the triage team, and hopefully we won't get to that point, does review a case, they aren't aware of that patient's gender, they aren't aware of that patient, who that patient is, or anything else. They're only aware of what they need to know relative to the guidelines that have been developed. And you should, and our regional health network and state are came together to develop many of those standards of care and those algorithms. So again, start that process early and now. Team preparation is one of the last things I want to talk about. It may seem silly to talk about PPE, but you know, you gotta, I don't know about other institutions, but it's really hard to get people to get their fit testing and their TB testing every year when there's not a pandemic. So do that now. And now people are much more willing to do it, believe it or not, and of course. So get everybody fit tested now, even if you don't have any cases in your region, get them PAPR trained. And as I said before, you are going to be delivering care in different settings and in different teams, and that requires training and drilling and simulation, and we're doing that, and we've done that several times a month. And we offer that to all of our faculty. We offer it to our residents, and in fact, we don't even allow our residents to go in and intubate or work in PAPRs until they've trained and drilled on it. So it's a good experience for them. And the final thing I want to say is, again, this is not an emergency department response. It is a hospital response, but it's also a regional response. Partner and collaborate with the region. As I said before in the early part of this presentation, the pandemic started in Seattle. There was one small case, but it really started in full through a case in a long-term care facility that then, you know, infected many people in that care facility. And what we've noticed now is that there are many what we call hotspots of long-term care facilities across the region. We, as UW Medicine, have gone out to those areas. We've worked with the Department of Health, helping them to distribute patients evenly across the region, even though we're not at surge right now, because we don't want one institution to be overwhelmed. So partner with your local and state Department of Health. Bring your healthcare coalition together to bring all the hospitals together. Now is the time we compete. We're in an age of healthcare finance and healthcare delivery where everybody's aligning and competing with each other. Now is not the time to compete. We will be stronger together. And so we brought hospitals together. And in fact, one of the things we're doing right now is working with Microsoft to stand up a regional COVID coordinating center. It's going to be called RC3, I guess. And that will help coordinate across the region and give visibility into the beds, the number of beds, the ICUs, acute care beds, isolation beds, and even PPE across the region. And the governor is basically going to state that every hospital needs to contribute to this data. And that will be key to our success and everybody's success. Think about those vulnerable populations, the SNFs and the shelters. They're in danger. We are working closely with DOH in this and other community organizations with regard to the shelters and the homeless patients. And unfortunately, Seattle has a large population of homeless patients. Work with your EMS agencies, your jail, and your Department of Corrections. That's another place that's great for telehealth. And if you could get telehealth in the SNFs, we have not been able to do that yet. That would be another opportunity. And for those academic health centers that are on the line, if you can stand up telehealth for ICUs, to reach out to more of the critical access hospitals and smaller hospitals that don't have as much support in critical care, that's another opportunity that we've begun to do here. It's really about building a coalition, and because that's the way we're going to be strong and succeed. This is just our web page that I'll share with you. You can go to this and get any resources that we've created. We want the public to be able to access, anybody to access. And my final thoughts would be, you know, begin planning now. It is a marathon. Take care of your team. They're just wonderful people. We have to take care of each other. Communication drives everything. Over communicate, practice and drill. It builds team. It not only does it build skill, but it builds teamwork and it builds confidence in your team. And collaborate regionally, because that's the way we're going to be. That's going to be critical to our success. And those are the links at the bottom to our resources. Thank you very much.
Susan, thank you very much for the excellent presentation. It really spans the challenges and some of the successes you've had with preparing for this. I have a question from Christian Ramers, and if Bruce, we can bring Christian into the field.
Yeah, I'm on. Can you hear me okay?
Yeah, great.
Great. Thanks, Dr. Stern. So I'm an infectious disease doc in San Diego, did my training up at University of Washington, so it's good to see you guys doing well, and thank you so much for sharing all your wisdom and experience. My question concerns PPE and the transition from single-use personal disposable PPE over into a cohorting situation with a hot and cold zone with extended use. My impression is that the donning and especially the doffing of PPE is a high risk of contamination for healthcare workers. And I'm wondering how you transitioned from single-use PPE over to a cohorting situation, and how you guard against cross-contamination of patients, and then how you ensure that the doffing procedures are followed.
So that's a great question. We are in the process of doing that right now. So we haven't quite done it. So what we've said is, so first of all, let me take the second question first, the doffing. You're right, absolutely, that is the most dangerous part of the procedure for the healthcare worker. So we have what we call doffficers. That's what we call them. I don't know if anybody else calls them that, but nobody is supposed to doff unless somebody is observing you and assisting you. And we have found that that's very helpful. We initially had folks watching you don and coaching you, but you end up getting limited supply. So we encourage people to be observed while they're donning, but we require that they have a dofficer when they're doffing. And so we use, if we're in one of our emergency departments with a closed room, we use the call light and somebody comes and helps you doff. With regard to moving from bed to bed, you're right, that can place a risk. And so we're gonna have to watch that carefully, I guess is what I've said. We work close with John Lynch, whom you probably know, who's overseeing our work in that area. It is an open room and there's no negative pressure in that room. So there's some risk regardless, but you have to be careful. Yeah.
Thank you, Susan. I want to move now to our next presentation, but just before I do that, I want to make sure people have already started really sharing their crowdsourcing information, and I want a quick reminder. Please answer, because it really helps us get a feel for what's going on. ED volume in the past 72 hours. What's your #1 clinical pearl in caring for these patients in the ED? The best clinical operations change you've made in response to COVID-19, and the biggest clinical operations challenge you've had in the past 3 days. Thank you. I'm going to now turn this over to our next speaker, Dr. Julian McGreevy. He's the medical director of the Mount Sinai Hospital Emergency Department in New York City. He's obviously a very busy man right now. He's completed his residency at Boston Medical Center, Boston University School of Medicine, and has served as a clinical ethicist in both Boston and New York, and teaches at the Harvard Center for Bioethics. Please, Dr. McGreevy.
Thank you so much for having me. And so thank you, Dr. Stern, for the excellent presentation. Can everyone see the slides?
Not quite yet, Joanne. Go ahead and share your screen.
Oh yeah, right. Okay, there we go. Okay, how's that?
Just go ahead into presentation. Perfect.
Okay, so I'm going to follow up really with just some quick practical tips that build on all of the things that Dr. Stern said. I think we have a very similar way of looking at this and have had to address very similar challenges. My background is in obviously clinical medicine, operations, and also ethics and public health, and so I sort of have all of those hats a little bit together as we're thinking through this, and so you'll see a little bit of a blend of that thinking, I think, from me. So the first thing is you can't be too prepared. And I don't mean to sound silly, but one of the high up leaders in our hospital a couple weeks ago just sort of pulled me aside and said, are we overreacting? And I really wasn't sure at the time, but I was like, I really don't think so. I don't think we can be too prepared, and thank goodness, because we've probably been about a week or two ahead of most of the big challenges. So you really cannot be too prepared. The second is to think system. So, and by that, I mean, whatever system means to you. So us at Mount Sinai, we're part of a large health system of, roughly 8 hospitals. But that's really not even big enough. I think as Dr. Stern said, this really has to be a regional response. So our health systems, the other health systems in the city that traditionally compete against one another, really are having to band together to make sure that resources are being maximized. So I think that's critical. The next is to think in phases. So understand a little bit about what's who's coming in the door. So we had our first case. We had the first case in New York State on roughly April 29th. And this was a medical worker who had traveled abroad. And prior to that, for about a month, we had been drilling and donning and doffing and using our airborne isolation rooms, had a bunch of sort of false alarms, and then we had this case. And really after that, everything ramped up. In the next week or two, it was a lot of asymptomatic patients, a lot of true worried well, no symptoms at all. And then shortly after that, within a week or a few days of that, we had our first case in the community that then spread very quickly. And we had pretty clear community spread within about a week or so that was identified. And so after that, we had many people that were coming in with mild cold and cough symptoms that were not worried well, that they in fact had symptoms, and we had to sort of sort out what to do with them. So prior to all those folks coming in, we took over a small clinic right next to the ER, about a 20-bed clinic, and turned it into sort of a low acuity respiratory zone. So everybody who showed up to the ED with cold or cough symptoms was met by a greeter at the front door, was escorted over to this zone, which is like 20 feet down the street, and was seen in there and discharged. At that time, and I'll mention this, sort of the testing was not entirely clear. At that time, we essentially were testing all these people and sending them home quickly. So that was that phase. We are now in the phase where all of our hospitals in the system, small and large, are getting a large volume of crashing patients, people coming in significant respiratory distress, or coming in looking fairly well, but being hypoxic and then crashing thereafter. So it's a totally different preparation where now it's really all about what other zones next to the ED have we been able to take over to create larger resuscitation areas. So totally different things. And I think the goal is to try to anticipate which phase you're going to be in and stay a week or two ahead of it. Create capacity before it seems necessary. So this goes back to you can't be too prepared. If you're asking yourself, do we really need to do this? Are we ready yet? You definitely do, because the goal is to have everything ramped up to be just sort of idle for a few days in the way you need it, because that volume is certainly going to come. And that's been true for us, both in our surge space, as well as our resuscitation space, and all of our spaces upstairs. Essentially, our hospital turned a number of ICUs into respiratory zones early. They laid empty for a couple of days, and then they were busy. And at this point, essentially the entire hospital is a respiratory zone. We have on the order, this is not an official number, but on the order of 600 COVID patients in the hospital, already, with an anticipation of somewhere in the order of 2,000 or more. Operate the ED command center continuously. So we've really had to centralize all of the work that is being done in terms of environmental services, materials management, respiratory, and all the other clinical services, so that although we have a hospital incident command center and a system incident command center, making sure that the ED has its own sort of leadership structure that is always ready to go 24/7. So we have one of our medical directors, one of our nursing directors really on at all times, knowing everything that's happening. And it's already been the case that a number of our leadership have gotten sick. And so being very clear about who your backup plan is if people get sick. Don't let uncertainty create confusion. So I think there's been lots of changes in guidelines. Who do you test? Who don't you test? What do you wear? Embrace the uncertainty, know it's coming, and tell all of your staff that there will be a lot of uncertainty. We'll give you the best evidence as we have it. Try to anticipate where you think that guidance from the city and state and other authorities is going to go based on your infectious disease experts and other people you have, so that you can kind of give people a little bit of a guess about where it's likely to go, so that they don't feel like you're just changing them all the time for no reason, but you're sort of moving with some sort of anticipation. Socialize the idea that clinical guidelines are dynamic. There are really no clear lines. They don't stay the same from day to day. And I think as we learn more about the disease, major things change. So I would say a week ago, we were saying intubate everybody early. As soon as they get to 6 liters, they're going to crash, intubate them early. Now we're sort of back at a spot where we're saying, well, you know what, some of these folks, even if they're a little older and have some comorbidities, they're sitting in the high 80s, if they don't look to be in significant distress, they're not working to breathe, maybe they're okay. And we're admitting some of these people to just kind of stay there for a couple of days and declare themselves one way or another. And a lot of them do seem to be doing well. And so that's been a little bit of a shift and change for us. I think as Dr. Stern said, palliative care is critical. I cannot emphasize this enough, that palliative care really needs to be seen as a critical care resource. What we've actually done is brought palliative care attendings down to the ED to be embedded as part of our resuscitation team. They are, at the same time that we're sort of preparing to resuscitate people, they're having conversations with the patients and their families. The families are all home. There's no visitors really at any hospital in New York. That they are here having conversations with the families. And I would say, I can't give real numbers, but a significant number of patients are saying, you know what, I really don't want to be intubated. And so that decision is being made based on their goals of care early, which I think is really critical. The next one, so my clinical ethics hat, is I think it's really important to sort of know the moral lens that you're working from. So as Dr. Stern said, there's been no declared crisis standard of care in New York. But I think for at least a week or two or more, people upstairs, throughout the city, we've seen this in some of the news from other hospitals, are wondering, should we be sort of being very careful about who we intubate and who we put in a critical care bed, lest we run out in a few days. The problem with that is that people, I think, are confusing who they're taking care of. Are they taking care of the one patient, or are they preparing for the all patients, right? Until crisis standards are declared, you're taking care of the one patient. And so I think, people are sometimes sort of making decisions for an individual patient in the back of their mind thinking, well, but what about the resources? And we have to be very careful not to conflate the two. I'll just sort of leave it at that. The final thing is that it's all COVID. At this point, our entire ED is COVID. We tried, one of our acute zones that was a cold zone, and we put up a little wall that lasted for 72 hours. We spared 72 hours of people being exposed, but at the end of the day, it's all COVID. The diarrhea is COVID, the chest pain is COVID, and all the rest. And so I think that's really critical in terms of our PPE, in terms of our index of suspicion. It's really all COVID. And I'll stop there.
Jolene, thank you so much for your presentation. I was struck by one particular phrase that you used, embrace the uncertainty. It reminds me of walking through the doors of the beginning of every shift in the emergency department. And for my colleagues in emergency medicine, I think that phrase strikes home to all of us and resonates with our reality, but in a much more profound way right now. I realize these rounds were scheduled for 1 hour. We will continue this for until 1:15 p.m. Eastern time, extend it by 15 minutes for those who wish to be able to continue to participate. It was not our intention, but the rich discussion and sharing of information, I think, is worth continuing to pursue for a little bit. I have a couple of questions, and by the way, for those of you who are on the panel, as in the Hollywood Squares or Brady Bunch here, feel free to raise your hands, and I'll try to just like in an audience, try to make sure I get the people as I can. First question is to Dr. Schneider. If you could get your go off of mute. Yeah, it's for Dr. Schneider. I, like probably everyone, was saddened to learn of the death of our fellow emergency physician that's widely presented on the news. And I guess from your leadership role with the American College of Emergency Physicians and the incomings into your email box, I don't know, maybe we should swap out. But my question is, what are you seeing to be really effective strategies in terms of emergency physicians, then I'm going to go to nursing, emergency physicians in supporting each other the best way possible? I mean, you know, you're living this right along with everyone, but you're seeing it in a different way that many others wouldn't. So what are you seeing as coping strategies that seem to be really, you know, supportive of emergency physicians being able to continue in this very long slog that we have ahead?
Rick, I wish I really knew, because that's really where ACEP is pivoting to right now. We have been you know, putting out materials and things on terms of how to treat this, PPE, all that type of stuff. And now we're really talking about resilience. How do we keep people going? We are working with Hilton, the various hotel chains. I know a lot of people are staying in hotels. We have just announced that Hilton is giving a big discount. We're talking with a cleaning product place to get cleaning products to all of you in your homes, food, etc. I really would love to hear from you guys. My email is sschneider, that's the German way, SSCHNEIDER @acep.org. What do you need? What can we do? We're also, by the way, setting up today a Facebook page for spouses and families.
That's
because
great.
although we go through this, right, you know, we, you know, this is like what we signed up for, and it's horrible, it's terrible. But I think the big thing is, we're here. That's where ACEP is moving right now. So please let me know. My inbox is destroyed anyhow, so just keep them coming. If I don't respond to you, it's because I'm 700 behind this morning, and that's not a lie. But we want to help you guys. This is horrible. We hope this would never happen. The other thing I would mention is we are hoping still to have an ACEP 20 meeting. I know a lot of people have had to cancel their meetings. And I got to tell you, we are planning one hell of a party, because this is, you know, this was our moment to shine. And then the third thing, while I'm thinking about it, we have the white hat. We've always had the white hat. ACEP has always had a white hat. Emergency physicians have always had a white hat on the Hill. Our hat has never been this white. And the whole world is watching what we're doing and understands the value of emergency medicine like they never did before. I just want to share with you a tweet we got from a hospitalist who says, "I promise never to ask about urine electrolytes again. I love what you guys are doing. I promise that will never happen." So we are seeing everyone understand the role that we have taken. Emergency physicians have never been this important in our country. And we're going to make sure the world understands that when this is over. Please, on behalf of ACEP, please be safe and let me know any ideas, no matter how crazy it is. We'll do it or think about it.
Thanks, Sandy. Mike Hastings, president of the Emergency Nurses Association, was on. He may have had to drop off. I don't see him on at this point. But Sharon Van Aersdale, if you wouldn't mind taking your mic off. And it's the same question I had for the physician community and emergency departments. What are you seeing being coping skills that you, ENA, others in nursing feel like are really being helpful right now?
Well, one, I want to go to that party that Sandy's talking about. So please invite us from the ED world, from the ED nursing world. I want to be in that. No, I think it's very much in line. It's how do you support the staff, make them feel comfortable and confident in the personal protective equipment. It's allowing them to be able to practice before they actually have to implement things so that they feel comfortable with flow. And it's, you know, I think a big part of this is the camaraderie. We've never been in a situation like this before, in this kind of crisis mode. And it's amazing to see the people coming together, the relationships, and how much that individuals are supporting each other. But, you know, here at Emory, we're also looking into telemedicine in the sense that it's not just for our patients, but it's also for our staff when they need it. So really utilizing faculty, staff, and assistance programs, and again, relying on each other.
And Rick, if I could say one more thing, ACEP started today. We're printing, we've given you, or I don't even know where it is, but you'll find it someplace on our web, a thank you card. Each day we're going to give you a thank you card to print out to give to your staff. Today's is to the housekeepers because we always forget them. It's available in English and Spanish. Most of the other ones will be available just in English. And we are just basically paying homage to the fact that this is a team. It's not the doctors, it's not the nurses, it's not the obvious people. It's a real team. And I don't mean to slight you nurses, because we got one coming up for you as well in a few days. Yes, thank you. But I thought the housekeepers are the ones that no one ever thinks of. And we all know if they don't turn around the rooms, we can't function.
Sandy, it was stunning to me as we learned in Las Vegas how housekeepers actually lives. I mean, literally saved lives because there weren't enough hands and literally stopped bleeding. And in this case, they actually also are saving lives by keeping us really safe in ways that no one ever predicted. So yeah, extraordinary. Yeah, housekeepers, absolutely. If there's an association of housekeepers, I'm happy to bring them on. Bring them into this. So a next question. Let me ask Susan McClellan, okay? If you can go off mute. And yeah, we're all trying to figure this whole Zoom platform learning, and Bruce is coaching me through it, but if you go off mute, can you, here's the question. Well, let me set up the question first. So I have been absolutely stunned by the number of EMS providers that are joining these calls. 27% for the critical care rounds. I mean, just amazing to me. So I think it's really important that, okay, so if you look at the ED, in my world, it's the centerpiece of medicine, but it's emergency physician perspective, obviously. So with that, we have all these EMS providers, and they actually want to know what's going to be helpful in terms of what they do as it relates to the emergency department. Are there things that they should do that they're not doing? Are they doing it exactly right? Sort of, what is that interface there that you see?
Okay, I'm not exactly sure why you asked me, because I'm the ID doc, but.
It's okay, but because you're the ID doc.
So in terms of patients, I think they need to be aware that clinically these patients can go downhill quickly, as has been spoken about. So availability of oxygen,
Perfect. Yeah,
I think is important. Also, the message that's already been given that anything can be COVID. So they need to be thinking about what's the most efficient way to protect. So from a PPE standpoint or from an infection control standpoint, one of the things that I think is worth thinking about is that protection from somebody else's secretions can be achieved somewhat by just putting something over that person's face. And so when we're talking about perfect masks for healthcare workers, quality of masks for healthcare workers, and so on, it's the idea of masking in order to prevent yourself from shedding or to prevent the patient from shedding to you doesn't require as good a mask. So we've seen, for example, patients being brought in who had N95 masks on because that's really unnecessary. A towel wrap, well, you don't really want to wrap a towel around their face, but some other type of either a procedure mask, such as I'm wearing, because we've gone to all masking all the time, or even if that's not available, if a patient can tolerate having a bandana or something like that around their mouth and nose, I think from the standpoint of transmission via respiratory aerosols and droplets, that would reduce risk and might be a way for EMTs to feel a little bit more comfortable with their own safety. Lots and lots of hand hygiene in that situation, of course. And I think that's sort of a message that might be a little bit helpful, is that these other patients you're worried about, that's one way to reduce potential contamination or spread. That doesn't involve layering on 5 layers of PPE onto yourself. I hope that's useful comment.
That's the kind, it's been stunning to see, the hundreds of questions, and some of many persist around PPE, as you might imagine. So I think that actually, that kind of messaging, or you're sharing that with the many who are undoubtedly from EMS on this call, I think was really helpful. Julian, yeah, I'm sorry, Bruce?
Hey, thanks. I just wanted to ask a follow-up question related to the EMT group. If Susan or Jolien could comment on criteria for either bringing patients to the ED or not bringing them.
Yeah.
So when they show
Big
up
one.
in a home for someone who's called 911, what guidance do you give them on whether they tell the patient it's best they stay at home and actually not come to the ED versus bringing them?
Okay, I'll start with mine. What I'm thinking and my concern for patients, for example, who've been tested but seemed mild and went home, is simply that we know so well that around 7 to 10 days, maybe a bit before, maybe a bit after of onset of what may seem to be mild symptoms, we see people going downhill in terms of their oxygenation. And we're assuming that's when a serious inflammatory response sets in. So some guidance might be, how long have you had symptoms? I'd be very concerned about someone who's like, I thought I was getting better, but this morning it just hurts to take a breath, or something like that. And especially if they have comorbid conditions. So that's one of the things that's on my mind that we're deciding whether somebody needs to come to the hospital.
Thanks. A question for both Jolien and Susan. Susan, I'll go to you first if it's okay. Given the question, I'm just going to read the question. Given many asymptomatic patients with COVID-19, should all patients be considered positive on first entry to the emergency department?
Okay.
I'm muting, sorry, yeah.
Yeah, no, I get it.
So I think, so I am not an infectious disease doctor, but my opinion is that I would say that either, and again, this may not agree with Dr. Lynch, so the gentleman from UCSD is still on, this may not agree with him, but I think we're in a phase where we don't know who's transmitting and who's not. And so what I would say is either all the healthcare workers who are on the front line, which includes the screeners, the cafeteria people who are checking people out when they're walking through the line, the triage folks, registration, all of those folks, either they should be masked or the patient. I don't necessarily think, and I think any symptomatic patient should be masked. The asymptomatic patients, I don't think necessarily if other people are wearing masks. So I think you can go either way. I'd be interested to hear what the infectious disease docs say though.
All right, I'm going to go to Jolien because he's the one with the avalanche of patients, the onslaught, and then I'll go to the ID people. How about that? Let's do it pretty rapidly because I got a couple more questions and we're like 7 minutes away before closing down. So Jolien, your approach on that?
Yeah, everybody wears a mask. Everybody who walks in the ER wears a mask. There's very few visitors, but for say end-of-life care or something, they wear masks. All their staff wear masks at all times. I think that's sort of the only way to do it given the volume that we have.
And to me, this dialogue is one of the huge values of this platform that I'm just learning right along with you because, this is evolving so fast. Guidances about this stuff are not going to be able to keep up with where they just can't. So it's really important. Yeah, Susan, unmute yourself.
I just wanted to say that our PPE criteria is probably the criteria that has changed the most from the very beginning. And we're not in the position where Jolien is right now, but we have just made the leap of, it's not mandatory masking now, but they're now allowing people to wear masks if they want all the time. So that's University of Washington's, the next step that they took 24 hours ago. But we have probably changed our PPE protocol probably no less than 5 times. And it's not random. I think this goes back to what Jolien was saying. It reflects change in situation. It reflects change in prevalence. And what Jolien was saying is really important. You want to try and anticipate and communicate ahead of time with your staff.
Yeah, thanks. And Susan had her hand up. And then after Susan, Sharon, if you could tee up and share the resources on the PPE from NETEC so everybody is aware. Okay, Susan. Thank you.
Very quickly, there's an excellent article on the rationale plus or minus between for universal masking that was just published in New England Journal of Medicine, and I highly recommend everybody read it. It has the pros and cons and the conditions under which it ought to be done.
Thanks, Susan. I wasn't aware of that. That's helpful to know.
Just came.
Let me go to Jolien. No, go to Sharon. Sharon, on PPE, just for awareness, I mean, we have been supporting your taxpayer dollars, and mine have been supporting the National Emerging Infectious Diseases Training and Education Center ever since Ebola. And they have extraordinary resources on training that could be very helpful to many who are on this call. So Sharon, you want to share what those are?
Absolutely. Thanks, Rick. And I echo what everybody is saying here. You know, the situation is evolving. The equipment that we have available is evolving. Recommendations, evidence, it's all evolving. And so we have to be fluid with the personal protective equipment used. We also just launched what we are calling social distancing masks, because in healthcare, we can't social distance. We have allowed staff to wear masks when they're in situations where they would normally social distance. But NETEC does have a lot of resources, and we do thank our taxpayers, and we thank HHS for supporting us for the last 5 years to be able to produce these amazing resources. So if you go to netec.org, that's our landing page, and there is a COVID-19 quick link, and you'll be directed to whole bunch of different types of resources. So there are just-in-time videos. There are checklists for how to put on and take off personal protective equipment. I know at Emory, we've really invested a lot of time and effort into using visual checklists for staff, you know, of how to take on, how to put on and take off personal protective equipment based off of the level of protection needed. So yeah, lots of effort's been put into that.
Thanks, Sharon. And then Jolien, I believe you had your hand up. Yes?
Yes, I just wanted to comment, sort of seeing all the EMS questions. We alluded to it a little bit. But you know, this really is an opportunity to think of the system as a whole, you know, depending on how your city or region works. But you know, we have a pretty significant community paramedicine activity here, where all the primary doctors can, if one of their patients calls them and they're not quite sure over the phone whether the person should or shouldn't come to the hospital, that they can potentially send a community paramedicine to their house to take a pulse ox, look at the patient, and to try to decide if the person can stay home or not. You know, a question someone asked is a pulse ox helpful at home? We haven't gone there yet, but if I could get my hands on, like, you know, 5,000 pulse oxes, you know, I would send them, have the primary doctors give them to their patients, and then the people that we send home, I would send them home with them, because I think that would make a difference. I think the ERs really have to collaborate with all of the ambulatory sites and EMS to sort of intentionally direct people to the right place at the right time. Otherwise, the systems won't be able to handle it.
Yeah, and Jolien, so everyone's aware, the telehealth and telemedicine is a cross-cutting activity of the FEMA Healthcare Resilience Task Force. It is high on everyone's radar screen and working at warp speed to try to, like, break down the barriers to telemedicine, telehealth that we've had for decades. And we've made some progress. It's not nearly fast. Nothing's fast enough right now. I think we really are going to need to, like, close out. It's like 1:13. I want to make sure housekeeping issues, and I can close this out. Bruce, housekeeping thing before I close this out.
Great, thanks, Rick, and thanks to our speakers and the panelists and everyone who joined today. Just want to remind everyone there are links in the chat to the continuing medical education survey, and you'll get instant CME if you complete that survey, or nursing credits, etc. So please, it's also, there should be a link in the announcement. So either go to the announcement or go to the chat and click there and give us the feedback so we can improve these. Thank you.
Thanks, Bruce, and to Project Echo. This platform is new for many of us. This peer-to-peer learning virtual platform, it was new to me, but as far as I can tell, it's working out pretty darn well. We have scheduled critical care rounds for next Tuesday. Again, a follow-up, a 2-week follow-up from the very first critical care rounds with the speakers from University of University of Minnesota, and also Emory. And then we have emergency department rounds next Thursday as well, and we plan on continuing that schedule. Sandy, I'm going to be like tapping into you again on the emergency medicine rounds, and my colleagues at NETEC as well. But we've got some, the intent is trying to get speakers who are on the curve or just like prepared for the curve, so we can help those that haven't quite hit yet. That's at least the strategy right now. Really appreciate the rich discussion. I think we've moved this sort of learning platform for these clinical rounds much more forward in terms of the interactive nature than we did previously, and want to continue in that vein so we can really learn from each other as this platform is designed for. Thank you so much for your attention and your time. Thank you.
Bye-bye, and thank you, everyone.
Bye.